Thank you guys for having me today. We're presenting a very interesting case, Zone 3 PAU with contained rupture and more surprises. So this is a 68-year-old man, had a previous infrarenal PAU, and he had underwent an EVAR in January this year, and then he developed a descending thoracic aortic PAU, and he underwent TEVAR a month later. And he comes in now with intermittent chest pain, more frequent abdominal pain, anemia, and weight loss for 3 months. He actually had a full workup, hematologic and GI workup that was all negative, cardiac workup that was negative. Lab-wise, only thing normal was his hemoglobin was he was anemic, 7.5 to 8, with a normal white count. On exam, he had a normal body habitus, nothing really remarkable on his exam. So here's the scans in January and February. You can see here a PAU in the infrarenal aorta. A gore excluder with a 24 main body was placed. A month later, he got a scan that showed a descending thoracic PAU, and a gore C-tag 34 by 100 was placed. So after the TEVAR and EVAR, he got a CAT scan. You can see here he's got a new Zone 3 penetrating aortic ulcer with a contained rupture. Of note, his prior TEVAR and EVAR didn't show an endo leak. So here's a sagittal view, and here's a 3D reconstruction. Here's my bad drawing and measurements, but you can see here he had about 2 centimeters from the left common carotid artery to the PAU, and this would come into our surgical plan. We planned for a left subcarotid subclavian transposition versus bypass to increase that proximal seal zone, followed by a stage TEVAR. Some of our judges were actually wrote an article on this, on debranching for TEVAR. So our first choice approach was to attempt the left carotid subclavian transposition instead of a bypass if the anatomy allowed for it. It avoids prosthetic, and you can argue it more definitively eliminates a type 2 endoleak by directly ligating the proximal left subclavian artery. We made a medial supraclavicular incision. We got to the carotid artery. We identified the thoracic duct and lymphatics, which were ligated and clipped, and we dissected out the left subclavian artery as proximal as possible and controlled the branches, which I've highlighted here. We felt the anatomy was suitable for a left carotid subclavian transposition, as there appeared to be adequate length to perform a tension-free anastomosis with the proximal left subclavian artery and left common carotid artery. You can see here we had to transect the left subclavian artery after ligating the left subclavian artery approximately, which I'm sure was a very stressful moment for my attending. And then we anastomosed end to side with 6-O-proline. Here's the final anastomosis in picture. He was extubated, he recovered fine, he remained neurologically intact, and was discharged day 1 with plan for stage TEVAR in 1 week. However, he presented to the ED actually 1 day prior to his scheduled TEVAR date with a fever of 1 day and mild cough. He otherwise denied all other symptoms. In that 1 day, we got as much of an infectious workup as possible. He was negative for COVID, negative for flu. His white count was normal. His chest X-ray was fine. He did have 1 blood culture that grew strep pneumonia, but his other 3s were negative. We ultimately decided to proceed with TEVAR as scheduled. So we shot our thoracic angiogram, which confirmed that large PAU in Zone 3, but he's also got this new outpouching just proximal to his prior TEVAR. So this is very concerning, and in retrospect, we're happy that we actually proceeded at this and not delayed his surgery, because we were concerned about this new outpouching. We deployed a 40 by 200 core C-tag. It deploys from proximal to distal first, and then you can adjust the angulation, and then you fully deploy it. Afterwards, what you see here, We landed it right here, right proximal to the left carotid artery. Right distal to the carotid artery. And then we bridged with another Gore-C tag to cover that new outpouching over here. Here's our completion angiogram. See our left carotid subclavian transposition. So we were happy with this. He recovered well, he remained neurologically intact, was discharged on day 1. He had resolution of his pain. We had planned to see him in the clinic with vascular medicine and rheumatology referrals and an interval CT scan in 2 weeks. But the surprises continue at his 2-week follow-up. While he felt fine, his interval CT scan showed this, which is very concerning to us. He had a new distal outpouching distal to that previous TVAR over here, and you can see it on the sagittal as well. So obviously this is a very challenging problem. Here's a 3D reconstruction. I measured about 14 millimeters from the distal end of that TVAR to the celiac and about 3 centimeters to the SMA. And we discussed several options with the patient and family, including a hybrid open visceral or renal debranching with distal extension of an endograft. That's obviously a very big operation. Another option is possibly occluding the celiac axis and extending to just above the SMA. You obviously have to confirm that there's good collateralization between the celiac and SMA, and you're now dependent on just the SMA for perfusing the viscerals. So that was very concerning, and obviously there's a very high chance of future degeneration at the level of SMA. We also discussed physician-modified endografts. As we know, this is not regulated. It requires multiple custom fenestrations, and it's probably only appropriate to be done by attendings or physicians who have multiple years of experience with this. Another option is laser fenestration. This risks ischemia time, fabric tears, and you also need multiple fenestrations. Another option is parallel grafting with sandwich snorkel technique to the viscerals and renals. Now, this is also complicated because we want to avoid coming from above due to the high risk of risking retrograde type A dissection, and also we can't come from the left side because he's got a transposition on that side. We ultimately referred this patient, Dr. McKinsey, who opted for parallel grafting, interestingly via femoral access. We had placed the spinal drain preoperatively. This was the initial angiogram, which confirmed that large dilatation and leak. You can see here he's got 3 left renal arteries. We selectively catheterized each renal artery, and it seemed to appear that they had nearly equal perfusion to the kidney. Maybe the distal one had the least amount, but this also played into our decision making. So following IVUS for sizing and identifying the branch vessels and a left femoral cut down, we deployed a tapered 34 by 30 relay prograft from the prior C-tag to just above the celiac axis. And then through the left groin, we selectively catheterized the celiac and SMA using Nagari steerable sheaths to position our 6x79 Gore VBX. For those who are not familiar, the Nagari sheath does not rely on pull wires. It uses true vector technology, and it's very good for preventing deflection of your sheath. So with our VBX position in the celiac and SMA, we positioned our 33 by 70 treo aortic cuff just proximal to the highest renal artery, sandwiching the VBXs. You can see that over here. We deployed the aortic cuff, but kept the top cap constrained so the proximal aspects of the VBX could land above it. And after we deployed the VBXs and used as an anchor to carefully withdraw our Nagari sheath below our cuff, and then we balloon angioplasty the VBXs and used the coda balloon for the treo and the Relay Pro stent grafts. We also reinforced and straightened out the celiac VBX with a self-expanding stent using a Nagari sheath. And here's our final aortogram over here. He recovered fine postoperatively. He remained neurologically intact. The spinal drain was removed on post-op day 3, and he was discharged on post-op day 4 with IV antibiotics for 6 weeks. This is an interval post-op CTA scan, which shows resolution of the prio-endo leak. So up to this point, the etiology of his aortic PAU, still remains unclear. You know, his infectious workup is thus far negative. The pathologist didn't find any evidence of connective tissue disorder at this point, and he's awaiting further vascular medicine evaluation. Thank you, guys.